Right. Hello, everybody. This is episode two. Today we're going to be kind of switching into talking more of more of an educational standpoint. So we're going to be talking about kind of a diagnostic workup and schema for chest pain, which is a little bit of a big undertaking. There's lots of things that can cause chest pain. Before we kind of get into that, I want to, put out a couple of disclaimers, obviously. So one, I'm a fourth year medical student. I am about 2 months out from graduating at this point. So the information that I'm going to give you is obviously from the perspective of a medical student. Now, I have gone through a fair bit of sub-Is, especially in internal medicine. So I feel like I'm fairly familiar with some of the more common, like bread and butter internal medicine type diagnoses and how we work them up and what preceptors want to hear from you as you're presenting and things like that. So I'll give you that perspective and kind of help you, create a framework for how do you want to discuss these things efficiently yet thoroughly so that when you're presenting to a preceptor, you have all the information you need in order for them to feel confident that you did a very thorough job when you're, interviewing the patient and when you're doing your physical exam and you've thought about what the next steps are, et cetera. So we'll kind of go through that. Now, I do say, obviously, that I'm talking from a fourth year medical student perspective because I can't possibly know everything that's out there. And there's always going to be somebody smarter than you in the room. And that's part of the learning experience is that you want to be surrounded by people that have more experience and more knowledge than you so that you can absorb some of that. And so this is me imparting what little I know onto you. I say that, but I also want to reassure you that the things that I do say are factual. I will make sure that as I'm giving this information to you, it will be all things that I've either taken out of like a step two book, which I have here with me, or something that I've heard from a preceptor on a rotation in the past, or something that I've witnessed, myself in the hospital. All of the things will be factual, and I will try to eliminate as many opinions as I can. And if I do have opinions, I'll make sure to explicitly state that so that if there's people out there watching these videos who are taking step one or step two. They don't, jump to a conclusion that I'm making that may be more of an opinion. But otherwise, I'm going to try to stick to the facts, very straightforward, keep the videos as short as I can, and really try to keep things simplified. The other caveat I want to mention is that I'm applying to internal medicine, as I mentioned in the first video. So all of the things that I'm going to tell you are coming from that perspective, just because that's the framework that I have in my mind. Everyone is going to have to go through internal medicine as a third year medical student anyway, so I think it's important to have, that framework, at least for that rotation. And then if you end up applying to internal medicine, you have it going forward as well. I think that some of this will help, if there's people out there wanting to do ER and stuff like that as well, because a lot of the initial diagnostic workups that I'm going to discuss will already have been completed for the most part in the ER. And then there's a couple of additional things that internal medicine physicians will kind of keep an eye on and maybe continue to check up on as a patient is admitted to the hospital. So those are the couple of caveats. And with this video, I know I said earlier that I wanted to try to keep these videos like as short as I can. I mentioned like 6 to 12 minutes earlier. This one is going to be a little bit longer, I think. Chest pain, there's such a broad differential for chest pain. I think it's going to be hard to keep it short, but I will be as efficient as possible as we go forward here. So we're going to kind of dive in. I have not done this type of formatting before as far as my like tutoring experience goes. It's a lot of just like one-on-one. Somebody comes in asking questions. I give them information and we kind of discuss like where the sticking points are. This is going to be a video where we just kind of do brief overview of here are some of the differentials. Here's what the preceptors are going to want to hear from you. Here's the physical exam things that you want to try to pinpoint, labs, imaging, things like that. Very broad overview. Um, and then kind of we'll dive into treatment and stuff at the end. So, um, let's start with, talking about chest pain. So chest pain, you have somebody come into the ER, they have chest pain. Let's talk about what steps you're going to go through with somebody who has chest pain. So obviously, the first thing I think a lot of medical students think about with chest pain is going to be ACS, right? Somebody who has a myocardial infarction. And that's certainly one of the more common things that you'll see coming through the hospital and a very common cause of chest pain. But there is, like I said, a large differential that we have to consider. So, step one always with chest pain is going to be assessing the stability of the patient. Now, obviously, if a resident or attending physician is giving you this patient to go see, it's likely that the patient is probably stable. They're not going to send you into a code on your first couple of days in internal medicine, especially as a medical student. You don't know how to run codes at this point, right? So, um, still, it's an important point to make. Always assess stability. Remember your ABCs, airway, breathing, circulation. Check all those things. Are they protecting their airway in the sense that they're able to breathe on their own? Um, what's their mental status? Are they breathing at a high rate? Are they, can you hear wheezing, et cetera? Just assessing generally like the eyeball test. How does a person look? Um, and start there. Now, like I said, a lot of the times you're going to be sent in as a third year, fourth year medical student, patient's going to be stable. So we'll check that off. We'll say the patient's stable, they have chest pain. So then you're going to go through and you're going to do your old carts or whatever your acronym is for making sure that you hit all the high points of, you know, your thorough history, right? So old carts is the way that we learned it. For those that don't know that, that's like onset, location, duration, characteristics, aggravating and alleviating factors, associated symptoms, radiation, timing, severity, as old carts basically summed up. And those are the elements that you want to get in your history. And now with chest pain, there's like a couple of things within that old carts and within maybe the full history that you want to make sure that you pinpoint. So the first one I think that's important is age. Age is going to help you kind of determine, okay, is this person intimately or immediately going to die, or is this person somebody who has uncontrolled GERD and now, they haven't been taking their PPI for 6 weeks because they're, 23 and partying and they've just forgotten. I think age can give you a good idea of what boxes of differentials you want to consider. So I always start there, look at the age, look at the sex, obviously. And then you kind of want to, with chest pain, think about kind of risk stratification, right? And we can talk a lot more about this as we go into differentials and diagnoses and things like that. But some questions you will want to ask, especially about their past medical history, in order to like fit that risk stratification box, is going to be like past medical history of diabetes, hypertension, hyperlipidemia. Do they smoke? Do they use drugs like cocaine, especially? Do they have a family history of cardiac arrest or myocardial infarction or any of those other diseases that I just listed? Another one that, maybe is a little bit more rare, but you could ask about connective tissue diseases like Marfan's. You think about aortic dissections or things like that. Now, those are some kind of immediate things that I would think about as you're talking to the patient. Some other things that a preceptor is really going to want to hear from you is a description of the chest pain. And this is a key point because in internal medicine, likely if this person is having ACS, especially a STEMI, you're going to end up calling cardiology. So you want to be able to describe the chest pain to them to really convince them like, hey, this person needs a cath right away. So you want to ask them, is this chest pain exertional? Does it come on more when you move around? Does it relieve with rest? Have you ever had these symptoms before? You want to talk about like associated symptoms because that can help kind of like with your review of systems. You want to kind of narrow down your differentials. So obviously chest pain, like I'm going to talk about here in a little bit, can come from all different systems. So you want to ask, are you having shortness of breath? Are you having abdominal pain? Have you had any diarrhea? Stuff like that. Headaches, etc. Are you making urine? Things like that are important to consider. And then you want to talk about obviously alleviating aggravating factors, kind of like with the exertion thing that we just talked about. And then is there any radiation of the pain, etc. So, like aortic dissection, classic, like radiation to the back, MI, radiation down the arm, up to the jaw, neck, etc. So ask those questions. Surgical history is also important because with chest pain, we think about pulmonary embolism as well as another differential, which we'll talk about. So you want to ask them, have you had recent surgery? Have you been immobilized recently because of a surgery or otherwise, including travel? And you want to ask about prior surgical history as well, in the term, in the sense like, have you had any cardiac surgeries or otherwise? That can be kind of a clue sometimes. And then, kind of like lower on the list of importance, I would ask about like recent trauma, cough, because it could be costochondritis and they maybe have like an irritation or a rib fracture if they're really old and have fragile bones, things like that. We talked about drug use and alcohol use is important to consider, and then the family history we talked about. So those are some of the key points I would try to pull out of the history in order to really have a good description of the chest pain and give your preceptor a good idea of here are the risk factors that this person has. I think that it's X, Y, and Z. And you can use that when you talk about the assessment and plan, like, well, they have these things. I want to do a stress test, even though it's stable angina, whatever, right? We'll get into that. So the next thing I want to talk about is just generally like objective data that a preceptor is going to want to hear from you. So we just went through all the subjective data and some things like some highlights that I would try to get out of the patient. And just kind of as a aside, it's not always possible in the hospital setting to get that thorough of a history. Some patients are not conscious. Some patients are very elderly and they don't know what medications they're taking. And in cases like that, you want to try to get some form of collateral, calling family, using your resources to try to find as much information as you can before you present that patient. So lots of chart review, looking through prior hospitalization visits, see what the medications were at their prior hospitalization, when were they in the hospital last, et cetera. So some objective data now that we want to talk about. So as you're going through, like in order of your presentation, you'll obviously give the vitals, and we decided that they were stable, so that's good. Physical exam. So in the physical exam, for chest pain, I think, always have a very broad differential. So you want to check a lot of different systems to see if there's any positives and also kind of ruling some stuff out. So I think for chest pain broadly, I would do cardiac exam, listen to the heart sounds, push on the chest, see if there's any reproducible tenderness that can help you as well. Um, you can do like peripheral circulation as well, kind of checking to see if there's like differential pulses for like aortic dissection or something like that. Respiratory exam, obviously, pulmonary can cause chest pain. So, we think about PE, we think about pneumonia, we think about pneumothorax, blah, blah, blah. So listen to the heart sounds. You can do your special tests if that really, if you think it's going to give you some more clinical information. Ultimately, I don't know a whole lot of attendings that care a lot about special tests because our imaging is so good. It's like we, you can, percuss the chest as much as you'd like. But we also have chest x-rays and CTs. So I don't know. Up to you. You decide. Um, Other things, abdominal exam. So you want to listen to the bowel sounds. You want to, push, especially in the epigastric region, because we talked about GERD. That reflux can really cause a lot of pain for people. That mimics chest pain. Um, an MSK exam, so similar to like pushing on the chest, that can give you like an idea if it's costochondritis, if there's trauma there, you want to maybe like see if they have a rib fracture or something like that, or a sternum fracture. They might be a little bit more unstable if that was the case, but things of that nature, keep that in mind. And then some other things that, you might not think about, but like herpes zoster, for example, shingles can be extremely painful and people might not realize that they have a rash. So make sure you look at the skin. That's a very important thing to do, especially when somebody's coming in for an initial admission. You want to look at the skin. The nurses do it too, but you should as well, just to be thorough. And then extremities, obviously, we think about like heart failure. Heart failure doesn't really cause chest pain per se, but you can get some like a type 2 end STEMI where it's a lot of just like demand ischemia from just poor ejection from the heart. And that, you can see in the extremities swelling and things like that. So you want to look at that and see. Also can give you a clue if they have like peripheral artery disease, they don't have any hair on their legs. That could give you a clue of like what their, overall cardiovascular status is. But so those are the things that I would look for on a physical exam. And then those are the things I would communicate to the preceptor too. Next, labs, imaging. Labs. So generally for like an initial chest pain workup, you'll see like CBC, CMP, troponins, BNP. Um, as far as labs go, I mean, initially that's probably the extent of what you'll get. You want to look at, how's their kidney function? You want to look at, do they have an infection like a leukocytosis? You want to look at any electrolyte disturbances that could give you a clue of, how their kidneys are working. What their BNP is can give you a clue if they have, some form of heart failure. And I won't go into all of like the diagnostic criteria as far as that goes. There's things that you should probably look up and know for yourself before the rotation. Um, but these are things that you'll commonly see. And the troponins obviously indication of like necrosis of the myocardium, et cetera. As far as imaging goes, there's going to be like EKG that you'll see, chest X-ray. They might do a fast exam if they think like somebody has cardiac tamponade. Like we said, this person's stable. But if somebody has cardiac tamponade, they might see on ultrasound a bunch of fluid around the heart, and that's like a surgical emergency. You'll do a pericardiocentesis and kind of drain all that out. Um, and then, depending on what the ER is suspicious of, they might get a CT angiogram if they think that this person has a pulmonary embolism or a stable aortic dissection, et cetera. So those are some things that you would initially want to work up. And I'll be more specific as we're going through the differentials here in the next little bit, but those are kind of like the broad chest pain workups that you'll see. And then we kind of, as a person gets admitted, if they're, going up into the hospital floor, more things will happen after that. If like somebody has stable angina, and you want to make sure that it's not something more severe, they'll have like a stress test, and there's like different ways of doing that, et cetera. But I won't get too far into that. The one thing I do want to discuss though is sorry, hold on. One thing that like preceptors might ask you about is D-dimers. So I think we learn in medical school, and it's probably getting phased out a little bit more now, but like the when you have somebody that comes in with like a suspected PE, that you should get a D-dimer, but that's ultimately not true. And in fact, a lot of preceptors will be upset with you if you say that, so that's why I wanted to mention it. D-dimers are great for telling you definitively that somebody doesn't have a pulmonary embolism or a clot. So if you have a very, very low suspicion that somebody has a pulmonary embolism or a DVT, um, get a D-dimer, because then if it's negative, you can rule that out. Otherwise, if you have even a moderate or mild suspicion that somebody has a PE, you'll just get a CT angio. I've also had preceptors tell me in the past, if somebody can't get a CT angio for whatever reason, that VQ scans are garbage. I personally don't have any experience with that. So I've had a radiologist and a internal medicine physician tell me that. Do with that information what you will. There are certain situations like pregnancy and stuff like that where, VQ scans might be your only option, or like, severe kidney disease, et cetera. So do with that information what you will. I don't think that's a high yield point necessarily, but something that you can just have in your back pocket of like, discussing things with your preceptor. So